So it now falls to me to introduce the Peter Tizzard Lecture for 2021. Professor Sir Peter Tizzard was a founder member of the Neonatal Society. Many of you will know he was Professor of Pediatrics at the Hammersmith and also at Oxford University, and was really instrumental to the setting up of this society back in 1959. Following his death, there was a named lecture set up after Professor Peter Tizzard, and there have been a long list of very eminent pioneers, really, in our field who've given that lecture over the years. Could I have the next slide, please? It's with real pleasure to announce that the awardee this year is Professor Neil Marlow. Neil was Professor of Neonatal Medicine at the University of Nottingham, and then latterly for the past 11 years at University College London, and retired in 2020. Neil, many of you will know, was the director of the MRC-funded Epicure studies, which have now been going for 25 years, and I was delighted to hear over dinner last night that there are plans for a further adult follow-up stage. And I think that body of work and other work that Neil has done has really places him among perhaps one of the world's leading people for the breadth and depth of understanding about the preterm infant and the fate that he or her faces as they pass through life. His work really has been world-leading for over 2 decades. In addition to understanding work around the preterm infant, he's been a major contributor to randomized controlled trials in the UK and beyond. He's held several key roles. He's been president of the British Association of Perinatal Medicine, he's been president of ESPR, and he's chaired 2 European Academy meetings. His academic esteem has been recognized by the Academy of Medical Sciences, of which he is a fellow, by being an emeritus senior investigator for the NIHR. And in 2019, I was delighted to see he was awarded a Lifetime Achievement from Bliss. With all of this, he's made substantial contributions to health policy for neonates at national level too. So it's with great pleasure, Neil, to welcome you to give the 2021 Tizzard Lecture.
Thank you very much indeed, James. And it's a real honour to be able to give the Tizzard Lecture tonight, particularly to this august body, and in person, which I think is a great tribute to the Neonatal Society. This is, I think, the first face-to-face meeting we've had since lockdown, and you're to be congratulated on it. I'm going to talk to you a little bit about the very long-term findings that we've got from our Epicure study. But first, I would just recall that around 43 years ago, over 43 years ago, I went to do my first paediatric SHO job at the Churchill in Oxford. There were 2 SHOs, myself and Pat Hamilton, who's well known to many of you. And we had a visitation from our consultant, Peter Tizzard, twice a week. And I remember the sessions he came very fondly, because he was actually, I suspect, very much more relaxed working in the general pediatrics away from the John Radcliffe. Sadly, he at the time did not want SHOs who hadn't got membership. So I had to go somewhere else to get my neonatal experience, and that's another story. At the time, Anne Stewart was working on what actually was one of the very first systematic reviews in the field. She reviewed all of the outcome studies since the middle 40s through to 1977. And she came to the conclusion that we were getting a lot better at looking after babies, and babies were highly likely to survive, and that we should move into a phase of brain-oriented care. And that brain orientation that you've seen today, the legacy of that, which came from Anne and Os Reynolds and other pioneers at the time. I moved to Manchester to do my neonatal training with Malcolm Tizzard, and we set about doing my first outcome study. And we looked at a cohort of babies who were born under 2,000 grams, so huge babies by today's standards. But I put this up just to remind you what outcomes were like back at that time. You can see that 50% survival was around 27, 28 weeks in Manchester, and that babies were very unlikely to survive under 27 weeks. We had a small proportion of children who had what we then called handicaps. And actually you can see from the rather square, home-drawn Venn diagrams that actually the bulk of our survivors who had problems had cerebral palsy. How things have changed over the years. So fast forward from 1980 to the middle 90s, and a group of investigators that's familiar to many of you, I suspect, in the room, Kate, Andrew, and Alan Gibson. And we sat together having dinner, as you do, in a nice restaurant, and we thought we were trying to design a trial for a well-known surfactant and its use in extremely preterm infants. And this young lady, Pat, came up with the idea of calling it Epicure. Well, the trial didn't work, but the name stuck. And we started in 1995 by collecting information. Initially, it was going to be in the big, the large hospitals, but eventually it was a whole country study. And then we were joined by the Irish, who wanted to come in on the act. So we actually had one of the very first targeted studies of extremely immature infants in the world. And we followed them right the way through for the last 25 years, and there's still data coming out from the last assessment. And it's a very well-described population with high rates of morbidity. We then went back in 2006 and did the whole thing again, just for England this time, because by then the difficulties of doing getting ethics in different countries and things that form the union was quite challenging. And we've seen those children at 3 and a sample of them at 11. And one of the reasons I put that up, though I'm not going to talk very much about that now, was that actually we've not seen huge differences in neonatal morbidities or in terms of the major morbidities or the outcomes across that 11-year gap. And that leads me to the question of what are the contemporary cohorts of extremely immature infants looking towards. Over the years, Epicure has been quite a large endeavour, and I have to acknowledge that there have been a large number of fellows and senior co-investigators who have worked very hard with us. In particular, Enid Hennessy and Joan Morris, who were the statisticians on the trial. Initially Joan moved to the States for a short period. Enid joined us and then would never give it back until she retired. Been supported more recently by adult physicians as well. As you'll see, I think that's really important. And the 19-year data I'm presenting were collected by Joe Beckman and Helen O'Reilly. A lot of the analysis has been done by our statistician, Yan Ni. So I'm going to just talk to you a little bit about how the baseline has changed over the last period since we started doing Epicure, to explore the range of outcomes in early adult life from a range of perspectives, some of which you will not have necessarily heard us talk about before, and to consider the implications of those outcomes. Over time, since 1995, we've seen survival change quite dramatically. And You can see here the gestational survival by gestational week for babies admitted for neonatal care. And you can see that actually now for the increasing number of babies who are born at 22 weeks, there is a prospect of survival that is equivalent, not far off being equivalent to the prospects that a child had at 24 weeks back in 1995. And that means that the baseline is continually changing. And you can see here, this is the proportion in the light grey bars of deaths, of neonatal deaths that occur in the totality of neonatal deaths under 24 weeks. And you can see that it's close to 50% at the moment. So it's the area where there is most activity and the highest mortality. But we know things are actually getting better, don't we? I mean, we know that, for example, our focus on survival has shown improvement. We also know that we've had significantly reduced rates of germinal matrix hemorrhage and a reduction in cerebral palsy seen over the last 20 years, shown by this beautiful set of graphs. I've taken two of them from the SCPE collaboration across Europe, which used to be able to collect data on cerebral palsy from UK registers until they were disbanded by the privacy laws, effectively. And you can see that we've, for very low birth weight babies, we've seen a steady decline from 1980 through to 2005. And for the extremely low birth weight group, we see a rise initially as survival started to improve. And then as we got better, we reached a peak, and now it's coming down. And I suspect that if we were able to do Epicure 3 now, we'd find many fewer children with cerebral palsy. At least I'd hope to think we were. So let's look at what happened to these children 20 years on from 1995. And I'm going to talk a little bit about the absolute outcomes, the trajectories that we've seen across childhood, and also think about some of the implications we have for adult diseases. It's always nice to start with a story, and this is a little lad called Ewan, who was born in the north of Scotland at 24 weeks in June 1995, and is one of our Epicure people, participants. And he suffered a major unilateral IVH with a hemorrhagic parenchymal infarction fairly soon after birth, and his parents were ushered into a small room and told in no uncertain terms that he was very unlikely to survive. And of course, as usual, when we try to predict things, 4 months later, he graduated from the NICU. He actually did develop cerebral palsy, and he had multiple surgeries, particularly to his right leg, his right hip and leg, multiple releases, and he walks with a stick. He passed his driving test when he was 17. He then went on to study musical composition at Aberdeen, and he plays the cello absolutely beautifully. He's undertaken a fundraiser and climbed to the top of Ben Nevis to raise money for his local neonatal unit. He was a Queen's baton bearer for the Olympic Flame. And he regularly gives talks about what it's like to be an ex-preterm individual around the region he lives in. And when I was approached by a television company to do a piece to accompany one of our publications, they arranged for him to come down and interview me. And we sat there talking, and we had a wonderful discussion. Anyone who knows me, and we talked about Elgar and Vaughan Williams, and he was absolutely knew everything there was to know about them, which was wonderful. And so we sat down, we got very serious, and he looked at me in the eye, and he said, "Well, Professor Marlow, should I have been saved?" And that is the problem, is that it became, for many people, a black and white thing. And I think, as we've seen in the latest iteration of our guidelines, that it's a much more nuanced thing we need to think about, because in many areas of the UK at the time we were doing Epicure, he would not have been offered active resuscitation. And we've had lovely examples today of how being born early is not just an opportunity to start again for the fetus. There are all sorts of antenatal problems, such as inflammation, infection, hypoxia, that go on, which lead to an extremely preterm birth. So the fetus, when he's born, is not a well fetus looking forward to a normal development, if only we can get it right. There are problems going on. And those problems were described by Joe Volpe particularly as a combination, an amalgam of destructive elements or injury and developmental disturbances to the brain. And we know that they produce a range of outcomes that we've described across childhood, from cerebral palsy to motor problems to core executive deficits with low IQ and behavioral problems. But we also forget that the same processes also affect the rest of the body. And we know very much from the excellent work that's been done around BPD that the injury to the lung that occurs during BPD is again that same complex amalgam of injuries that occur from ventilation usually, and inflammation that is secondary to perinatal inflammation, and a developmental arrest, which leads to the lungs being simpler and smaller right the way through until probably in the mid-last trimester. And we see that particularly clearly with the eye, when after birth the reduction in the hormonal environment and the challenge of hyperoxia leads to retinal hypoxia, which, when the hormonal imbalance is resurrected at 31, 32 weeks, leads to new vessel formation and blindness. We also have very little information about what happens to other organs, such as, for example, the kidney, which may be very important, may suffer from oligonephronia, and of course might be an important life-limiting outcome. So what about this transition to a young adult life? Let's start by looking at this. Well, I've shown this many times because these are the neurocognitive outcomes that we're most interested in and we're most focused on in terms of cognition, behavior, education, and socialization. And these are really important things. Lots of people have now got cohorts of preterm children past the magic witching age of 18. And we're able to put lots of studies together. And this year we reported the first of the individual patient meta-analyses that we've done in collaboration with other centres around the world. And that's the top list of cohorts, are all part of the RECAP preterm study. And you can see that the Epicure study looks to have the biggest cognitive deficit, but they are all organised on the mean gestational age of the cohort. And the Epicure cohort is very much more immature than most cohorts, so tends to have the most florid impairments. There are also aggregate data that we've seen from other studies that we weren't able to include in an IPD. And you can see that around about roughly 1 standard deviation deficit in IQ awaits our graduates when they get to adult life. It is, of course, a complete continuum, and Jill Pell's group from Glasgow has done some lovely work looking at this in various ways. In one of their analyses, they put together all the IQ scores they could. The size of the circle reflects the size of the study, and they put a straight line through it. The question is, should they have put a straight line through it? Because actually, if you look at it again, it may well be increasing in terms of the discrepancy as you get more and more immature. And certainly in terms of other analyses that have been done, it's been an almost exponential curve. And so the challenge for us, if we're going to improve cognitive outcomes by adult life, is to actually change the slope of that exponential curve, which is quite challenging because it's across the board. We also know that when we have a group of extremely immature infants, they have quite a complex cognitive impairment. And you can break cognition down into a whole group of executive functions. And Helen did this when she was looking at our 19-year-olds. And we had a group of 10 different executive functions that she tested. And you can look at the distribution there. On the left are the extremely preterm participants. And you see that only 40% of them had no executive deficit. And some of them had deficits right the way across the board. So certainly we're seeing a very complex problem down at these very low gestations. We were also quite surprised when we looked at the stability of the observations we made in childhood. We'd always assumed that you could get better as time went on, but actually the data that we've collected seems to show a really quite flat prediction. And if you use a range of linear modeling, you see there's actually no change between 6 and 19 in terms of the IQ, and most children stay reasonably well on track. And we all worry about social factors, and probably the most widely used one is maternal education. And you can see on the right the effect of maternal education to split by O-level or below, or A-level or higher. And you can see that it has an effect on both the term controls and the preterms, but it's a small constant effect over childhood and not something that necessarily changes. We know also that we see a lot of behavioural problems amongst the children that we look after. And many of my community paediatric colleagues say we shouldn't be doing it because they see sometimes some complex problems. These two are equally stable. On the left is a graph. We've stratified it by the child behaviour checklist scores at 2 years because we switched to using a different behavioural screener after that. And you can see that the scores remain remarkably consistent over childhood. We also stratified it by those that had cognitive impairment, because they would have higher scores, as you see there, and because behavioural problems are particularly found amongst those that have lower IQ. And that too is fairly constant across childhood. Sam Johnson has worked with me for nearly 20 years now on this project. Also has written extensively around behavioural problems. And we see this phenotype, which we've called a preterm behavioural phenotype, where we have internalizing problems mainly. And you can see that in our group at 19 on the left, that externalizing problems are sat absolutely no more, no greater, no less in the preterm group. But on the right, you see the profile where we see internalizing depression, anxiety, and avoidant personality, and strangely ADHD in that group. But the ADHD is not what you think of as ADHD, in that you've got the naughty boys, and we haven't got any in here, because they're normally sitting at the front of the class where the teacher can throw chalk at them. But actually, this is inattentive type ADHD, which is to some extent a little bit more debilitating, because it means it's not picked up frequently by teachers in class, and these children go through childhood without it really being properly recognized. Many people will have heard that people have started to screen for autism phenotype in this thing, and we were able to use the broad autism phenotype at 19 years, which was fantastic. And this is a very well-respected new scale. And you can see that the impairment scores of aloof, rigidity, pragmatic, and total BAPQ scores are significantly higher in our extremely preterm group. If we look at the facial effect score, you'd expect higher scores to be better, as well as empathy quotients, higher scores to be better, and indeed they are significantly better in the controls. And we keep this proportion of about 8% who meet research diagnosis for autism, ASD. It's not a clinical diagnosis, it's a research diagnosis, which makes it a little bit more difficult to explain to people, because many of the children who score highly on this have not been diagnosed as such with the condition. It correlates with other questionnaires that we use, such as social communication questionnaire, and it's particularly related to having a low IQ. The issue of psychiatric outcomes is very important. And a group from Norway did a lovely national study where they looked at adult diagnoses some years ago now. But I find this quite a worrying graph, in that this is the divided into 5 gestational age groups, and then the risk, the relative risk of schizophrenia, autism, or other broad psychiatric disorders. And you can see that both autism and the psychiatric disorders show a very clear relationship of being significantly more prevalent at the lower gestations. And schizophrenia, which is something that has worried many of us over the years, including Anne Stewart, who passed her cohort on to the Institute of Psychiatry because she was so worried about it. And you can see at the bottom end, there's just that suggestion that schizophrenia might be important. Of course, none of the studies have been big enough to pick this up, because the population prevalence is only around about 1%. And the peak age of diagnosis of schizophrenia is in your 3rd decade. And most of us haven't got to that yet. So we're still slightly anxious about those outcomes. We turn from the hard numbers to the sort of the socialization and the social outcomes we have. One of the first things people do is, what are their quality of life? Well, quality of life is a really difficult concept. And most people use the Health Utilities Index, multi-attribute system, to score this as a utility, 1 being normal and 0 being the worst. And you can see that if we use these self-report ones highlighted in red from this thing at the bottom, that the extremely preterm children who don't have impairments still have a significantly reduced multi-attribute utility. These attributes, though, are not really what I think of as quality of life, but actually more very much health-related domains. And you can see that the number of domains which goes from left to right, 0 being on the left and all 4 more than or equal to 4 domains on the right, are actually not that different in distribution between the controls and the extremely preterm infants. And that's something that we find constantly. If you ask the individuals themselves, they perceive themselves as being much less affected than often their parents or caregivers do. The WHO has changed the way it looks at impairments, disabilities and handicaps, and has come up with this new international classification, which I think is fascinating and is a really good way of looking at things. It's done in 5 domains in terms of cognition, executive function, self-care, academic attainment, and social participation. And those functions are arranged around 3 levels, which are optimal, at risk, or challenged. And if we look at that, you can get a composite whole person performance out of it. And that's described as able, struggling, or restricted. And Mary Sullivan and Mike Mazzor from Chicago have been looking at this really quite carefully over the last few years, and published a lovely paper in seminars last year. And this is the Chicago cohort, who they saw at 17. And you look at the differences. Most of the children that they saw had optimal outcomes on these scores. There was a small excess of challenged individuals within the preterm group, and those often had physical impairments. If you look at the top right figure, we have the differences between boys and girls on the left, which reflects the fact that most of the outcomes that we look at are much worse in boys than girls. And you can see the difference between the total preterm and term group over the whole person functioning scale. And if you look at the bottom graph, this is around socioeconomic status, and you see the interaction between advantage, disadvantage, and your whole person functioning. And those who are in the most disadvantaged group actually are those who have the particularly worse outcomes in terms of their ability to function within this framework. So we've got a lot of work to do to understand that. And then we get headlines like this, which come along, which really must worry most parents when they see them. Amongst our group, we know that their education attainment through senior school was actually less than their controls. You can see fewer had A-level or BTECs and more had low-grade GCSEs. But when we look at where they were placed when they were 19, you can see that similar proportions are in full-time education, have jobs, full-time, part-time, vocational jobs. There's a small excess of disability in the Epicure group, and unemployment rates are the same between the two of them. So maybe that long-term outcome is not quite as bad as we think it's going to be, certainly in early adult life. Now, the late and much missed Maureen Hack from Cleveland, Ohio, followed a group of children through to 22. And she produced these wonderful data, which I've graphed here, looking at the some of the social profiles that they worry about in Cleveland. And you can see that the odds of using alcohol or recreational drugs were lower amongst the preterms than they were amongst the term children. You can see that there's a trend for them to have less contact with the police, to be convicted less often, and to be incarcerated less often. And there's also, sadly, the less opportunity or less frequently reported intercourse and amongst the girls having children. And these were cited as being good members of society. But actually, I give to you that they actually reflect very clearly the preterm phenotype that we were talking about before, in that if you're introverted, internalized, you don't actually relate to a peer group well. If you don't relate well to a peer group, there's not the peer pressure on you to drink too much, take recreational drugs, have sex, and get into trouble with the police. You know, and actually this reflects that profile quite nicely, and that profile has been very well described over the last few years. Another doyen of follow-up is Sarah Segal, who works with a cohort in Hamilton, Ontario, from McMaster. And she's now completed her 30-year follow-up, and she tells me it's hard work, but she's now on a 40-year follow-up of her cohort. And you can see that in her group, total group, they're less likely to be in employment, less likely to be in full-time employment, and more likely to be on social assistance. That they're more likely to be single, not to have sexual intercourse, they have fewer children, and they also have this strange thing that they're non-heterosexual more frequently. They also have the same profile of recreational drugs, drug dependence, and alcohol as Maureen's cohort. But in this group, although as a group their income was 20,000 Canadian dollars less, they had quite a lot of chronic health problems. And when you took those with chronic health problems out, those differences disappeared. And so there was, by and large, quite a positive reaction to those things. But we need to go further. We need to see actually how this has happened. And we're planning currently to at least contact and see if we can encourage the Epicure cohort to come back when they're 30, which I think will be quite interesting. Now, we think about the brain as being the most important thing, and I think a huge proportion of what we've seen presented at this lovely meeting has been about the brain, and it's undoubtedly important. But it needs one or two other organs to get going, and those other organs may well be much more important to the ex-preterm adults as they grow up. In terms of somatic growth, we're able now to plot the progress of the cohort from birth through expected date of delivery, 2.5 years, 6, 11, and 19 years. And you can see that in terms of weight, there has been quite a lot of catch-up from the nadir when they went home at expected date of delivery. You can see that height has remained fairly discrepant across the whole time period. And the end result of that is the bottom right chart, where we see the BMI, and these children have traditionally had a very low BMI, actually now just crossing zero and accelerating. And so we have to watch that, because of course that may bring with it significant risk. The head growth, which is the bottom left chart, is the one that has always worried me most. But I'm actually somewhat reassured that there has been some head growth, but still at 19, these children have heads that are 1 standard deviation below their colleagues. So let's go just a little bit further into their somatic outcomes, and let's think a little bit about cardiovascular function. We know that very preterm and now extremely preterm children have small but significant elevations of their blood pressure. This is central blood pressure measured as part of a vascular assessment that we did. So it's highly reliable, and it's measured in exactly the same way at the 2 ages. And then if we look at the augmentation index, which is a measure of the wave of reflection that comes back during systole, and if you have stiff arteries, you get a higher reflectance, which gives you a higher augmentation index. And it should be around 0 at 1920. And you can see for the controls, it is 0, effectively. But for the preterm, the extremely preterm children, there's a significant elevation of about 6%, which suggests that they are at risk of cardiovascular disorders. So one of the nice things about seeing young adults is if you want a blood sample, you can have an armful instead of half a mil. Yeah, what a difference. So we also looked at 1 or 2 other markers, and we measured desmosine as a measure of collagen turnover, because one of the elastin turnover in particular, because one of the things that we assumed was that they had a higher turnover, which is leading to stiffer arteries, but actually it was reduced. And we measured the CRP, which was no different between the 2 groups, thank God. We measured creatinine, which was elevated, but when we calculated the estimated EGFR, it was not different between the groups. And we did albumin, creatinine ratio, etc. Then we put them all into a regression to look at to see whether they affected the things. And the thing that surprised us was that we knew that the extremely preterm with and without BPD were likely that was likely to be related to both the augmentation index, and we thought the pulse wave velocity, though it wasn't. But the EGFR that we saw in this group was quite tightly related to both of those outcomes, which means I think we have to go back and look at the kidneys again and think very hard about renal outcomes for this group. I think it might be very important. We also know that the heart rate of extremely preterm children is a little elevated, and the mean arterial pressure, mean arterial pressure is also slightly elevated, and both of those are related to some of the vascular markers that we've had. So certainly there's things there to think about in terms of cardiovascular outcomes. And then what about the respiratory outcomes? Well, on the right, we've got the Z-scores of FEV1, post-bronchodilator, so this is when they're at their best, and you can see that there's a general drift down, which I suspect is the standards rather than the participants themselves. But you can see that there are significantly lower FEV1 scores for those that have had BPD in the newborn period, those who are extremely preterm without BPD, and then for the controls. And if we look at the results of giving a bronchodilator to these individuals, we see that the percentage change of FEV1 is higher in those with BPD, and one would assume that that is related to a reversible airways disease. So we measured their exhaled nitric oxide, and we were staggered to find that actually, as a marker of inflammation in the airways, this was actually lower in the extremely preterm group, and there were fewer of them that had over 40 parts per billion. This is after looking at cigarette smoking, which was actually very, very uncommon amongst the extremely preterm group. And correcting for that, it was still significantly lower in the extremely preterm group. So a strange mixture of things there. And we also, it was quite nice after the lecture we had on the first day, we actually looked at the respiratory microbiome by inducing coughing in this group. It's not a nice thing to do. So we may have fewer people coming back at 30, but you know, but we did it anyway because we thought we got an opportunity to look at it, and it was fascinating because the extremely preterm group had less rich microbiomes, less variant in their microbiome, and the diversity index was lower. That P equals 0.5 is between the BPD and the controls group. Sorry, I just noticed a mistake on that. And then we looked at their subtypes, and we found that they were particularly had lower Bacteroidetes groups in it, particular the Prevanella that was being talked about yesterday, and that the gap was filled by increasing firmicutes, and that was basically shows us really nicely that even 20 years later, we can see the effects of BPD on what's actually going on in the airwaves, which is, I think, quite frightening. And one of the reasons we were worried about it was this famous graph from Fletcher and Pito about what happens to your lung function over adult life. I'm just looking around to see if there are many people in the audience who are 25. Yeah, well, that's when, if you can remember that back that far, that's when you're at your physical peak. And then your function falls off. But actually, most of us don't notice it. But if you smoke or you've got symptoms of chronic obstructive pulmonary disease, then it falls off very much faster, and that's the two top lines there. Of course, if you're born extremely immaturely, you hit 70% of your peak predicted, because the lungs have failed to grow and develop in the same way. And of course, if there is accelerated decline, then you are likely to be hitting symptoms when you're 50, which is quite salutary. The fact that we've got lower rates of collagen and elastin turnover, that we've got lower concentrations of nitric oxide in the airway, even though there's an excess of children who have more reversible things, gives me a little bit of hope that it's not going to be only a small proportion that actually have an accelerated decline. But there you go. That's quite a challenge. So if we put it all together, we have implications for mental health, possibly for cognitive decline, which occurs, as many of us have found out, in the same way as the respiratory decline. There's the respiratory decline, there's cardiovascular risk, there's a metabolic risk. There's a small excess of children who have metabolic syndrome amongst the epicure group. Renal function. Nina Modi's group has shown that telomere shortening, which is a marker of accelerated aging, might be something that we see within this group. And there's a lovely paper just come out from the McMaster group looking at epigenetic markers of aging, which again seem to be accelerated in the preterm group. And we've got this male risk. So we've got a really complex system that we're trying to follow up. And most of us, for our follow-up, just do the Bailey. Well, there's lots of other things we should be doing and thinking about. And as I say, it is a very complex thing, a complex system. And that complex system has huge implications for mental health, education, earning, health, and aging, which might be important. So we look at some of our outcomes, and we look back at the neonatal period to see what predicts them. And there are actually relatively few risk studies that have been done as statisticians like them to be done. Lou Linsell from the MPEU did this for us, and did a systematic review of risk factor studies. And those that are to the right were significant in the final models. And of those, there are two things that stand out. Brain injury is the most preventable, and we've seen brain injury fall off over the last, certainly in terms of major IVH, fall off over the last 20 years. But bronchopulmonary dysplasia, we were shown beautifully by our prize winner today that actually that's still a very common problem amongst these children. And we've shown no change really in the pattern of neonatal morbidity. And when you look at the NICHD database for these major morbidities, neck, sepsis, intracranial hemorrhage, PVL, retinopathy, BPD, they're not actually making huge inroads into those either. So I still firmly believe that by getting our care right, by causing as little injury as we possibly can, and by facilitating the right environment for the child to grow, that many of these long-term problems can be ameliorated to some extent. So in conclusion, performance measures that we make in childhood reassuringly track well into adult life, even though we might not want them to. And graduates without impairment still have challenges. I think assessments that we do should include measures of functional domains and social outcomes, because those are the things that matter to the children and to the grown-ups when they get there. I think we need to understand aging in this group a bit better. I really do. And I think adult clinicians need to learn to take a perinatal history when they see people. They need to know, as teachers need to know, I think adult physicians need to know that these children, when they're adults, were extremely preterm. And there are clinics that are running around, particularly around chest outcomes post-BPD for adults now. Charlotte Bolton runs one up in Nottingham, and our colleagues run one at the Royal Free. And so I think our clinical practice needs to take a very long view. And I think it's really important that when we provide neonatal care, that we have a view to these potential outcomes and think about what we're doing when we exhibit some of the rather powerful medicines that and interventions that we offer to extremely preterm infants. And perhaps we need to think very hard about doing less damage and ways of trying to do that. One of the things that's happened over the last couple of years, I've met many more graduates, and I've asked one or two of them what they wanted me to tell you about their lives. And this is Alexandra, who's a teacher. She teaches in a secondary school, so she's pretty robust. I'd like people to know that despite being extremely preterm, I've managed to achieve the same things as a full-term babies, in some respects more. And she goes on to list her attainments. And I think it's great. And she's very proud of it. And she's very helpful in telling us about this. And more preterm adults, they're not ex-preterm adults because they still have problems of prematurity as adults. They are preterm adults, are actually coming forward to tell us about their experiences and to try and make us very much more aware of the problems that they're likely to see. Thank you very much indeed.
Thank you, Neil. That was a fantastically broad and very deep look at this complex problem of preterm infants. Does anybody have any comments or questions? Yeah, Sarah Bates.
Hi Neil, just absolutely amazing, completely inspiring. I have two questions moulded into one really. It's about your comment of how can we do things differently. And the first is, I wonder whether you could share your thoughts on whether the changes in family-centred care now may impact that phenotype that you see, the introverted, behavioural, social difficulties. Is that going to be different now because we allow a different family approach now? And the second part of the question is, in your opinion, what is the main intervention that we aren't doing enough of that would change things for our current cohort?
Do you mind repeating back for the online?
Thanks. Two parts to the question. One about the impact that engaging parents more in the baby's care has had on some of these outcomes, and what do I think we should be doing as a basic thing we could change our practice over. Well, I think when I first went to what's now St Michael's in Bristol, there was a viewing corridor rather, down the back of the neonatal unit. It wasn't built with parents in mind. And I do very much feel that engagement of parents right from the very beginning will change their perception of their child quite fundamentally. And I do actually think that much of the problems that we see over the first 2 years could be ameliorated by getting that right, mainly because of the anxiety that parents have over that early period. And regularizing that, I would hope, would make things better. Showing it is a very different matter. But I do think that actually making our care much more humane. I always love it when Neil Finer puts on his, and he won't mind me saying it because I've told him many times, he puts on his resuscitation videos and they're banging away on this, this poor baby on the resuscitator, and I'm thinking, hang on a minute, if you came into your neonatal society meeting and you had to go through that as a way of waking up, you probably wouldn't enjoy it. And And you wonder about how that initial introduction into the world is managed actually might make a huge difference to what we're doing. So I mean, I do think that we have to think our care and think the structure of our care and how it is affecting potentially the person that's in front of them. It does sound very touchy-feely, but I think it's the right thing. And the one thing I remember vividly is that over the years, I did quite a few oncology jobs when I was training. And we used to fill children with leukemia with 10, 12 antimitotics and various other procedures and various things as they were growing up. And then suddenly someone had the wonderful idea of actually, instead of increasing the number of drugs in the various iterations of UCAL, to actually start reducing them. And now you come in with a good prognosis leukemia and you get a shot of steroids and it's gone. You know, it's actually, I think, getting those sort of things right if we possibly can. And, you know, bronchopulmonary dysplasia is such a problem that actually strategies to avoid ventilation, I think, are really, really important. There's lots of things we can do. But we have to think about it when we're actually delivering the care. It's all right talking about it here, but it's how you get that message out and it working actually in practice. Yeah.
I think I saw a hand from Divian Shah.
Oh, Divian, hi.
Neil, given the comprehensive look at all the problems that ex-preterms face that you have described very nicely, I wonder what your thoughts are on our current trend of resuscitating 22-week gestation babies.
Well, I mean, I don't have a problem with it. If you actually talk to the children, and most of us don't follow them up for long enough to be able to talk to them, have a meaningful conversation with them. And most of them, like Ewan, are actually quite thoughtful and engaging individuals. And if you ask them, I shouldn't be the one you're asking, really. It should be them that you're asking. Has it all been worth it? You know, and very few of them will say no, it's not. And I do think that we can recognise the problems and we can try our best to put them right, and we can support them where they have problems. But many of the children you see don't have those problems. And of course, we only see those with problems. You know, and when we're talking to parents, we talk about the problems the child's had, not at how well he's done today. You know, a lovely mum came up to me in front of a lot of colleagues and said, "Oh, hello, Professor, nice to see you again. You were the only person who was nice to me about my child." I won't tell you where I was working then. But she was complaining that everyone came and told her about the problems the child had, and no one said, actually, he's really done well today, you know. And I think that's part of the engaging parents better and talking to parents, is actually managing the message that we give out.
You presented so wonderfully preterm birth as a multi-organ life course problem.
Yeah.
Which for researchers presents a vast challenge, a vast set of research challenges that you know, is much more expansive than we've perhaps considered 10, 15 years ago. What are the research priorities in your mind? You know, what do you want the researchers over the next 10 years to have solved when you're 10 years down the line in retirement?
I want to work out what early markers of some of the somatic problems are. I think that's something that I've come home to. I mean, a lovely girl. We were in a meeting with a focus group when we were setting up one of the recent studies, and she backed me into a corner and said, "My lungs finish here." And she showed me her Harrison sulcus, which was a long way away from where Harrison sulcus should be. And she said, that's what I want people to get right. So, I mean, I think we do have to work out what markers there are of some of these conditions and get in there to sort it out. I think I can give you an absolute priority, because I think that we've got a lot to learn. And I think going into it with our eyes open, and what I hope we've done through Epicure and 20 years of following them up, is actually show you the spread of things that we have to think about. Nobody said looking after small babies was easy. I think when you look at the spread of outcomes, it's a lot harder.
Well, thank you very much again. It was a fantastic lecture and discussion.
Thank you very much indeed.